out tonight for this Living Well and Bell session on women's health. And I'm so happy to have several of my colleagues here with me today. Dr. Kathy Kimmy is in the Department of Internal Medicine, and she runs the high-risk breast cancer clinic at Baylor Scott & White. And next to her is Dr. Kelsey Kelso, works with me in the Department of OBGYN, and she delivers a lot of babies, does surgery and everything, but also has a focus on perimenopause and menopause. And over at the end, Dr. Joanna Stacy, also one of my colleagues in the Department of OBGYN. Joanna does everything also, but also has a focus on adolescents, but also does, once again, delivering babies and taking care of hot flashes and everything. So tonight we want to cover some of the hot topics in women's health. And we're going to, and we want to answer your questions, okay? So have your questions ready if we don't cover them. And we're going to start off with Dr. Kathy Kimmy, because breast cancer is something that's a concern to all of us. We all either have personally experienced it or know someone who has, and it's the most common cancer in women. Not the most common cancer killer in women. What cancer kills more women than breast cancer? Lung cancer. Lung cancer. But breast cancer is the most common. So, Kathy, you get a lot of common questions. So we talked about it. This would be a great time for you to answer the most common questions that you get.
Okay. All right. So one of the questions I get every day in the breast clinic is, when should I have a mammogram? And let me say that mammograms save lives. Having a screening mammogram reduces your risk of dying from breast cancer. So mammograms are very, very important because breast cancer is most commonly found on a screening mammogram. But the experts really can't agree on when we should start a mammogram, how often we should have one, and when we should stop. Just recently, the National Comprehensive Cancer Network, NCCN, put out some guidelines, and they kind of simplified things, and it makes it easier for me because I like simple things. And so they said that we should start screening mammograms at age 40, and you should have a yearly mammogram starting at age 40. Sometimes we'll start sooner. We'll start 10 years prior to the youngest person in the family developing breast cancer. But the youngest we start a screening mammogram is age 30. So when should you stop having a mammogram? You know, that's really the discussion you need to have with your provider. Some say 75, but you know, I have some 76, 77-year-old women who continue to have mammograms because they're in good shape. And I also have women who are 75 that say, you know, it doesn't matter what we find on this mammogram, I'm not going to do anything about it. So, you know, it's really an individual decision that you need to make with your provider on when to stop. And, you know, now we are required to release your mammogram report to you, not only mammogram report, but all other reports too, for you to interpret or Google or something. But one thing that is on your mammogram is a statement about your breast density. And the radiologists are required to make a statement about breast density. And there's also sort of a paragraph that says, you know, dense breasts make it harder to see on mammogram, and you might want to do some supplemental screening, and maybe you need an MRI. Well, that's all well and good, but insurance won't pay for an MRI just because your breasts are dense. Now, dense breasts, that's something we see on mammogram. It's not something you feel. You can't feel the breast density. It's something we see on mammogram. And there's nothing you can do to make your breasts less dense. There's nothing you did to make your breasts more dense. It's just how God made you. It is what it is, and we have to deal with it. But dense breasts can mask things on mammogram. They can mask things on mammogram, and having dense breasts is an independent risk factor for breast cancer. So let me show you, Patsy said we couldn't have slides, but I did bring something to illustrate dense breasts. Dense breasts show up as something white. You have a white background, and cancer often shows up as something white. So if you're trying to find white specks on a white background, it's hard. So the density masks your mammogram. If there's one place in your body where you want fat, Patsy, it's in your breasts, because we can see through fat, but we can't put fat where we want fat, unfortunately, right? All right, so this is a fatty replaced breast. Fat shows up as a black background, and it's easy to see white specks on a black background, okay? So dense breasts, fatty replaced breasts, we really can't control that. We just have to deal with it as best we can. So if you have dense breasts, I think it's important to know your breast density. Then you need a 3D mammogram. A 3D mammogram gives us more than just 2 pictures of your breast. You know, the routine mammogram, you're squashed this way and you're squashed this way. The 3D is the same squash, unfortunately, but you're squashed this way, and then the camera takes pictures at different levels. So you get slices of your breast, and the computer puts all that together, and we get a much better picture. So a 3D mammogram is the way to go if you have dense breasts. So let's say you're having a mammogram tomorrow, and you don't know if it's 3D or not, but you get there and you ask the lady when you check in, is this a 3D mammogram? Oh no, it's just a regular one. You can request a 3D mammogram. I called the mammogram people yesterday, and they said, yes, you can request a 3D mammogram. Even when you get there tomorrow, you can request a 3D mammogram, and you need that if your breasts are dense. So 3D mammogram. You might also need an MRI, but getting an MRI is tricky. We have to come up with other risk factors and other ways for insurance to cover an MRI, which kind of leads to the next question. Do you need an MRI? It would be nice if we could do MRIs just for dense breasts, but we can't. Insurance won't cover it. Now, when I say insurance won't cover it, MRIs are very, very expensive. And even if insurance approves the MRI, you'll likely make a copay for that MRI. So you have to be prepared for that. I've heard people say, you know, my MRI copay was $200. Mine was $500. Someone this week told me that when she got there, they said, that'll be $1,500. You know, that's expensive, but she paid it and got her MRI. So insurance will cover an MRI if you have a genetic mutation, and like BRCA1 or BRCA2, those are just 2 of the common ones. If you're a first-degree relative of someone who has a BRCA1 or BRCA2 or other genetic mutation, if you haven't been tested. Some women have had genetic testing already and they're negative. So if you're an untested first-degree relative of someone with a genetic mutation, you can have an MRI. If you had radiation to your chest wall, like in childhood for lymphoma, insurance will go for an MRI. Or if your lifetime risk for breast cancer is over 20%. And so you have to have your risk assessed, and you have to know what your lifetime risk is. So when I put on the MRI request, lifetime risk 25%, they're almost always going to cover that. So you have to have your risk assessed. So that comes to the next question is, what is my risk for breast cancer, and what can I do to reduce my risk? There are models on the computer where I can put in information, and I can tell you your risk for breast cancer over the next 5 years, 10 years, and your lifetime. And depending on what that is, you know, you may be at high risk. If your lifetime risk is over 20%, we can get the MRI. There are other things we can do to reduce your risk for breast cancer. Probably the most radical thing we could do would be remove your breast. But we don't do that very often. Only if you had a genetic mutation would we talk about it. That's a big decision, a huge decision, but it reduces your risk more than anything else we can offer. There are actually medicines we can use to reduce the risk for breast cancer. There are 4 medicines that have been approved to reduce the risk for breast cancer in women at high risk. There are lifestyle changes that we can make to reduce our risk for breast cancer. Exercise. The recommendation is 150 to 300 minutes a week of a moderate intensity exercise, something that really gets your heart rate up. Walking, Zumba, swimming, treadmill, anything that gets your heart rate up will help. I tell women every day, because, we all want a pill for something, right? I say exercise is a medication to reduce your risk for breast cancer. Think of it like that. Maintain a normal body weight. That's very important. So if you are thin, stay thin. If you're not thin, get thin. And I know that's easier said than done. I realize that, and that's a whole different discussion. But that's very important. And limit alcohol. We were talking just a minute ago that really the recommendation now is that we probably shouldn't drink. We have to think of alcohol as a carcinogen for breast cancer. I don't smoke because I don't want to get lung cancer, but we should probably not drink or limit our drinking so that we won't get breast cancer. The recommendation, if you're going to drink, is not every day, and when you drink, only one. You can't save them all up and have them on the weekend. All right, I've heard it all. One is 5 ounces of wine. So you have to measure. It's not 1 glass of wine this big. 5 ounces of wine, 1.5 ounces of hard liquor, or 12 ounces of beer. Yeah. Okay, so that's the recommendation. The other question I get a lot is, should I have genetic testing? Everybody wants genetic testing. Just a couple of things about that. You can inherit a mutation, which is a change in a gene, from your mother or your father. So it's not just women. Men can have mutations. Men can get breast cancer also. It's best to test the person in the family with cancer if they're alive and can be tested. Some people don't want to be tested. So if the person with cancer is not alive or doesn't want to be tested, then the next closest relative is the one that could be tested. There are certain red flags that pop up when I'm talking to a woman about her family history that make me think that there might be a mutation in the family. And those are if there are women who are diagnosed with breast cancer when they're less than 50. If a woman has cancer in both breasts, not necessarily the same time, one 10 years later the other, but the first one was less than 50. If there's ovarian cancer in the family at any age, if there are men in the family with breast cancer, or if you're of Ashkenazi Jewish descent, those are just some of the common red flags. There are others, but those are just some of the common red flags. Genetic testing is a blood test. You can also do a saliva test. So it is just a blood test, but you have to jump through some hoops before you get to that blood test. And it's not like, oh, we'll just add that genetic testing to the cholesterol I'm getting tomorrow. It's not that simple. It's actually a visit by itself. I have to go over a consent form. There's paperwork, there's computer work. We have to get a detailed family history. And then you go to the lab, and then the blood is FedExed to either a lab in California that we use or a lab in Utah. So we don't run the test at Scott and White. We draw the blood, but we send it to a very, very specialized lab for them to do the testing. The genetic mutations that increase the risk for breast cancer are actually very, very rare. Less than 10% of the time, breast cancer is caused by a genetic mutation. So it's not as common as people think. We've all heard of Angelina Jolie, you know, I mean, I just read this in People magazine. I don't have any insight on Angelina. But her mother, Angelina's mother, had ovarian cancer and was tested and had BRCA1 mutation. So Angelina was tested and she had BRCA1 mutation. So she had her breast removed and later had her ovaries removed. So if you have a genetic mutation, your risk can be very, very high, even though the mutations can be very rare. Let me just say a word about 23andMe. You've all heard of 23andMe, and I have people come in and say, oh, I don't have BRCA1 or 2 because I got tested on 23andMe and I'm negative. Well, you know, it's not quite that simple. There are different variations of BRCA1 and BRCA2. Just like we have different variations of soft drinks, we have Coke, Dr. Pepper, Sprite, 7-Up. There are different variations of BRCA1 and BRCA2. There are 3 variations of BRCA1 and BRCA2, 2 of the ones and 1 of the 2 that are in the 23andMe testing. And those variations are the variations that are most common in people of Ashkenazi Jewish descent, and they're rare in people of other ethnicities. So if you get 23andMe tested and you're not of Ashkenazi Jewish descent, you didn't learn much, but you thought you did. You know, you think you don't have BRCA1 or BRCA2. So I think the 23andMe people have done a tremendous job of marketing their product to us, but we have to really know more about that. So those are the common questions I get. I get other questions, and I know y'all will have questions later on that I'll be happy to answer.
Okay, well, I'll ask one question right now before
All right.
we go on to Dr. Kelso. Can we space those annual mammograms out? Like I'm going to be 70 next month. Can I start spacing these suckers out?
No, you need a yearly mammogram.
Well, that was quick, wasn't it?
Yeah, right. No, I would say no, because as we get older, our risk for breast cancer goes up. And, you know, you may have dense breasts, and we need to get every peek at your breast we can get, you know.
Okay.
So I would say no.
Okay, all right, thank you. Dr. Kelso, tell us a little bit about this hormonal transition, you know, the perimenopause.
I think you usually call it a roller coaster.
Well, I call it sex hormones in transition, SHIT.
Well, on that note, so yes, in a menopause clinic, you know, dealing with the menopause transition can be a really significant time for a woman. You know, the transition from the reproductive years when we go from regular menstrual cycles into this time of transition, kind of a roller coaster. So going from those 28 or 30-day cycles now into where each menstrual cycle is just various, whatever the hormones decide to do for that month. And so during that time of transition, we can start to see changes in the cycle length. And that's usually the first clue that menopause is on the horizon, is starting to see those cycle changes. And that's usually when we can start to see symptoms. I think when we think of perimenopause, we all think of hot flashes. That's kind of the hallmark symptom of menopause. But lots of symptoms. A great cohort study through women in our nation called the SWAN study, women reported symptoms, and the most commonly reported symptoms during this time of transition are joint pain, muscle aches, brain fog, difficulty concentrating, certainly hot flashes, night sweats, midline weight gain, depressive or mood symptoms. And so this constellation of symptoms can really disrupt sleep, can disrupt normal lifestyle work functions, and so dealing with those symptoms. And so one is just recognizing that those symptoms can come during that time. You know, women will come to the clinic and say, I have this and this and this and this, something must be really wrong with me, but it's part of that hormone transition. The other things to think about is when we start going through that transition, those hormone signals signal other things. So for women, it's a time of increased cardiovascular disease risk. It's a time for increased risk of low bone density or transition to osteoporosis. So it's a time that women really need to kind of buckle down on their health. The things she talked about, prevention of breast cancer, routine exercise, 150 to 300 minutes per week, can decrease risk of osteoporosis or hip fracture, decrease risk of cardiovascular disease. So it's a wonderful time and opportunity to really take advantage of getting on top of your health.
Exercise keeps coming up. Yeah.
Yeah.
And as women are going through this transition, a lot of times what I hear from patients is, I just feel old. Because we have estrogen receptors all over our body, in our joints, and that's why joint pain is one of the most common symptoms next to hot flashes. Women just start feeling achy all over because now they don't have that estrogen. And so they start, now some women, they sail through this, not that big of a deal, but the most common symptom, I think, are these hot flashes. And can you go over some of the treatments for hot flashes?
Sure. Well, first is always the lifestyle changes. So things that you can do just for comfort, dressing in layers, avoiding hot beverages, avoiding things that, may trigger that response. Beyond that, looking at certainly the most effective therapy for hot flashes is hormone therapy. So estrogen is the most effective therapy. And there's various ways that estrogen can be delivered, whether pills, patches, etc. And then there's non-hormonal therapies that have great evidence for treatment for women. So using low-dose antidepressants are well studied to prevent and reduce the severity and frequency of hot flashes, and also decrease sleep-related problems that come with menopause. Oxybutynin, which is a medicine for overactive bladder, has good evidence for preventing hot flashes, as well as gabapentin, which is a medicine typically used for chronic or neuropathic pain or even seizures. I'm answering a spam call here. They might learn something about menopause. So those are all different options that you can review with your provider and maybe even address 2 issues that are common in the menopause at once. The other symptom we think about these symptoms being prominent at the time just before the final menstrual period and in the year or so afterwards. The other symptoms that women will see with estrogen deficiency is the genitourinary syndrome of menopause. So we also have estrogen receptors in the bladder, in the urethra, in the vagina, in the vulva. And so that decreased estrogen, that is not something that tends to get better with time. Hot flashes tend to get better with time, but these vulvovaginal urinary symptoms tend to be progressive through the menopause.
Yeah. And some of the therapies for the vulvovaginal dryness, the vaginal dryness, can you go over some of that?
Yeah, so vaginal or local estrogen, many women are candidates for this, and this can be used long-term. Systemic hormone therapy, we have to think about various risk and duration of use, but these vaginal therapies can be used long-term. There's pills, there's patches, there's creams, there's a vaginal ring, different things that can be used to target locally to the vagina.
All right. I know we're going to probably get a lot of questions on that, but good summary there. I love it. And Dr. Stacy, I know you deal with all of women's issues, but we kind of want you to focus on adolescents' menstrual disorders and those issues.
And dealing with teenagers is also sex hormones in transition, if you haven't ever dealt with that. And it's almost like menopause in reverse. It's the coming on board of all those symptoms. And that's commonly what I will get. I will have patients and their parents coming in and saying, her periods are terrible, but we don't know really what that means. And it could be too few periods, too many periods, too much bleeding, not enough bleeding. And my job is to kind of sort those out. There's not a medical reason you actually need to be having a period menstrual cycle every month unless you are actively trying to get pregnant, and then you need to have that ovulation. So we do a lot of things these days to help suppress periods for a wide variety of reasons. We actually run a bleeding disorder clinic that we see a lot of our teenage girls in because they will bleed down to the level of being anemic. And so sometimes suppressing periods or starting a hormonal medication is very helpful for them to keep them from getting anemia. So the first thing we do is we talk to them about what is considered normal. And just like perimenopause is a time of transition where periods are spaced out, we have a lot more leeway in teenagers and adolescents on what is normal. So we allow their periods to be a little bit more spaced out and a little bit more erratic. But after 3 or more years of being after the start of puberty and periods, they really should be fairly regular, but it doesn't have to be exactly 28 days apart. 28-day menstrual cycle is simply an average of everybody put together. So yours may be 25 days from the start of the one to the next one, and then the next month may be 28 or 32, but that's all considered pretty normal. When I talk to patients and their parents, I say they really shouldn't last more than a week. Periods should be coming roughly once a month. It shouldn't be soaking pads or products, within under an hour. And we actually use a pretty good questionnaire to help quantify, because if you ask a person, are your periods heavy? Most women outside of gynecologists don't know what anybody else's periods are really like. So sometimes we have to quantify that, and what somebody may think, oh, that's not a big deal, but I can't ever figure out why I'm anemic every single time I go. Well, once we quantify that, they're really bleeding a lot, and we need to do some extra investigation. Versus other women will come to us and say, I feel like the toilet is filling up with blood, I'm bleeding so much, but yet their blood count is really normal. So a good gynecologist will help quantify that and really educate. So some reasons why bleeding may be too much can be separated really into 2 big categories. It might be a structural problem, a problem within the uterus, such as a fibroid or a leiomyoma, a little polyp or endometriosis. And we can usually figure that out by seeing if periods are regular around the same time each month. Versus a hormonal issue, and it can be anything. It doesn't have to be a sex hormone. It doesn't have to be something wrong with estrogen and progesterone. And I'm sure Dr. Kelso gets this. I need my hormones tested. And we usually tell people to pump the brakes a little bit. I can test hormones, but I might not test the hormones you think I'm going to test. Because thyroid is a really powerful hormone, and it's a very common organ to have some dysfunction. So we often talk to them about family history of thyroid problems. When was the last time your thyroid was checked? Because thyroid problems can really lead to a lot of menstrual problems. Again, in my younger population, we check for bleeding disorders. There's some very common bleeding disorders that are fairly not well known, but we see them once we start checking for them. So, if you've ever been told you're extremely anemic, or you've had to need a blood transfusion, either after delivering a baby or surgery, or even with a heavy period, you should be checked for a bleeding disorder. Other common things are like polycystic ovary syndrome, which is it's a very ambiguous name. It suggests there's something wrong with the ovaries, but the ovaries are fine. They're just not getting a good signal between the brain, the ovaries, and the uterus. So periods can be very dysfunctional. They can be very spread out for a while and then very close together. And when they get close together or prolonged, then it can lead to the anemia and the bleeding problems. So if you are having period problems or your child is having period problems, you might need to do some teasing, some blood work to really get it straightened out. The good news is, though, once you get past adolescence and into 20s, 30s, and 40s, there's often a nice time frame where periods tend to coast, people can have babies and do just fine, and then it kind of gets all messed up again around menopause.
Well, I think what's interesting is now we're into more commonly having menstrual suppression because women are delaying childbearing. In fact, let's throw a quiz out there, throw a question to you out there. Teen pregnancy, is it going up or going down? Teen pregnancy is down over 70% from the high in 1991. It's down 70%. Women having babies in their 20s going down. In the early 30s going down. Now, although they still have most of the babies, the increase in rate is in women in their late 30s and early 40s. Women are delaying childbearing. but they're still having all these periods, and sometimes they're problem periods. And if we look, what we're doing now, and definitely what I did was not natural. I had, both of my kids, I only had 2 kids, and I had them in my 30s. Took me forever to find somebody to marry me. Okay? But I guess my head was in a book too often. But that was anything, that was anything but natural. But it was normal. All me and my friends were doing it. We were all in medical school, and we were delaying childbearing because we were delaying marriage and everything else. So what we're seeing in modern women is a delay in childbearing. We're not doing actually what we were meant to do biologically, like what my mother did, have 7 kids, a few miscarriages in there, breastfeed. I asked my mom once, I said, "Mom, you never talked about your periods. Did you have problems with your periods?" And she said, "I don't remember having that many." And now if we look what's happening, girls are having periods earlier. And a lot of that has to do with nutrition, body fat, things like this. And women are having periods a little bit later. All right? And so a lot of people don't realize what's the average age for women now is getting close to 80, or it was getting close to 80. COVID knocked it down a couple of years. But the lifespan for women is really up there. But in 1900, the lifespan for women was 47. 47. That was the average lifespan. So what happened was, you started having periods, you got married, you started having a bunch of kids and breastfed, and then you died. That was natural.
And periods didn't start till you were 16 or 17.
And your periods didn't start till, so they started later, exactly. And they ended earlier in some women, And so what we're doing now is we're seeing women delaying childbearing, but they're having all these problem periods, so we're more apt to get into what we call menstrual suppression. These girls that are flooding every month, they're missing school, they're missing their athletic events, they're the star pitcher for the softball team, and it's the big game, and they're flooding, cramping in the bathroom.
And they always make them wear white pants.
What?
And softball players always wear white
pants, And so now we're more apt to get into menstrual suppression. So the question is, when is it okay not to have periods, and when do you need to be having periods? Obviously, if you want to get pregnant, you need to be having a period every month. That's a good sign that the hypothalamus is talking to the pituitary gland, is talking to the ovaries, and everything's working well. But unless you want to get pregnant, there's a way we can safely suppress menstruation, and you don't have to have all those menstrual problems. In fact, there's some benefits to menstrual suppression. Can you go over that some, Dr.
Sure,
Stacy?
and I'm going to start with the most common misperception, and that parents are very concerned about, and rightly so. If we're stopping the periods, where's the blood going? And thankfully, it is not building up inside of the uterus like an overfilled water balloon that's going to burst the floodgates. Luckily, the way our hormone regimens are designed, they are designed with extra progesterone instead of extra estrogen, which continually thins out that lining. And so that lining will get thinner and thinner and thinner and eventually won't bleed. So nothing is being plugged up or stopped up, thankfully. Sometimes you can get into a problem where it's too thin, but that's fairly easily correctable as well. We have a huge wide variety of medications we can take. And when I am talking to younger girls who are not sexually active, who are not in it for preventing pregnancy, I present it as hormone suppression pills because that really is what it is. I do not encourage my children that I see to engage in sexual activity as teenagers. That's not safe either. Of course, if they need contraception, we're going to provide that. But we can use a wide variety of things like birth control pills. There's about 40 different combinations of estrogen and progesterone we can use to suppress periods, make them lighter, make them less crampy. And you can't assume that not everybody wants to have a period. What am I trying to say? You can't assume everybody wants to stop periods. Some people feel very reassured having a period every month, but it shouldn't be trying to kill you in the process. That's not healthy either. So we can tailor it to patients based on what they want their periods really look like. You want to have a period every 3 months? Great. We will do hormone suppression and then take a break every 3 months. Are we shooting for no periods whatsoever because I have a really busy gymnastic schedule, or I have a bleeding disorder and I really might die if I start a period? Then we have other medicines like the Depo-Provera shot or even an IUD in children that we can put in under sedation that are very, very effective at controlling periods and keeping people from really being a detriment to their health.
And actually, having a period month after month, year after year, decade after decade,
It gets old
it is
fast.
not natural, and that increases our risk of ovarian cancer, endometrial cancer, endometriosis, fibroid growth. So our menstrual suppression medications, as Dr. Stacy said, are progesterone dominant, not estrogen dominant, and they can prevent fibroids, prevent cysts, and dramatically lower our risk of ovarian cancer. A lot of women are not aware of that, how birth control pills just decrease the risk of ovarian cancer by about 80% in women who've taken them at least 10 years.
Yeah.
So there are some benefits to menstrual suppression, and there are some risks to incessant ovulation. And as gynecologists, we get to see all of those risks.
Also, all those products are not good for the environment.
Yes.
Really, really bad for the environment.
Stop red, go green.
Right.
Okay.
Well, and I think that's another point too. Using these menstrual suppression or hormone therapy to suppress makes it okay to not need to have a menstrual period. But I think the red flag would be women that aren't on hormone suppression. If they're not menstruating regularly, that can be a risk factor. We're not progesterone dominant then, we're probably estrogen dominant, and you can build up an abnormal lining that can be a precursor to endometrial cancer or precancer. And so not menstruating regularly in the absence of hormone therapy needs evaluation.
Exactly. If you're not on one of these hormone therapies and you're not having periods every month, something is screwed up, and we need to figure out what that is. You know, could it be a thyroid disorder or something else? We need to figure out what that is. Now, before we jump into all your questions, I asked all the panelists to come up with their top 5 things that could help women be healthier, okay? And we're going to start with Dr. Stacy.
Okay.
Okay?
She made
So
me write it down.
the top 5 recommendations you have for women to help them stay healthier and happier.
And it was hard just coming up with 5,
Yeah.
but okay. So the number 1, do not smoke. Even though it's associated with lung cancer, it's really associated with every type of cancer. It's associated with thinning bones, brain fog. It's not attractive, but do not smoke. It is the worst thing you could possibly do for your health. I'm a big proponent of vaccination, and I know that we could probably do a whole nother talk just on that, but we've forgotten in this day and age what childhood illnesses used to be like, and we're starting to see some of them come back, like measles and mumps. And it's only a matter of time, in my opinion, before we start to see some of the really threatening ones. And being an adolescent gynecologist, if you haven't gotten your 11 to 15-year-old vaccinated against human papillomavirus, that is one of the biggest cancer prevention vaccinations you can get.
For girls and boys.
Girls and boys, exactly. And I have 4 daughters myself, and they all get it for their 12th birthday, so that's their little birthday present. Contraception. Even though we said we may not be suppressing periods for contraception, contraception in general has been one of the worldwide biggest things to advance women, not only in this country, but in other countries as well. When you can plan your children and space them apart, and you're not having to deal with unintended pregnancies, we know that women will advance. I put exercise/healthy diet. They could each be separate one, but we've already heard that exercise theme. It's one of the best antidepressants you could be on. It is one of the best things you can do. You've heard other health benefits for it. It does help regulate your hormones. And then my last one is love yourself for who you are. You're not anybody else. And so that is a good part of being mentally healthy. You know, you shouldn't strive to be somebody else. You need to love who you are and the body that you're in, and you can optimize it. You may never be a size 0, and there's good things about not being a size. That's a setup for osteoporosis.
I think a size 0 is a fetus.
Probably is.
Yeah. Good. Wow, I'm glad you brought up vaccinations. Vaccinations are the greatest invention of medicine. The greatest invention of medicine. We have wiped out some diseases like smallpox. We take for granted that that would kill millions of people every year. Vaccinations are the greatest invention of medicine of all time, slam dunk, nothing compares it. And we now have vaccines that can prevent cancer, like human papillomavirus. And and now we know that HPV causes over 50% of the cancer of the throat, particularly in guys. Get the guys vaccinated also. Great list. Hey, thank you. All right, Dr. Kelso, you're top 5. But mine are totally different. This is going to be fun. I love it.
Perfect. My number 1 is to get your physical health screenings. There's so many screening tools available. We talked about mammogram, HPV screening, Pap screening, bone density screening. These are opportunities for prevention. Instead of dealing with disease or dealing with late disease, it's an opportunity for prevention. Number 2 is to treat our mental health as well as we treat our physical health. I think sometimes we are good about getting those mammograms or Pap smears, but not giving that same attention to our mental health needs. Number 3 is sleep. Sleep. You can't bank it. I know.
Okay.
I know. We're both MDs.
A couple of obstetricians here. Sleep.
But you can't bank it up. You can't save it for later. We need sleep for our well-being. Number 4 is exercise for all the reasons she said, for our bone health, for our cardiovascular health, for our mental health, for breast cancer prevention, so many benefits to routine exercise. And then my number 5 is to have a passion and a purpose, and I would say outside of work or outside of your financial realm, something that, you know, makes you excited about the day and your contribution to people.
All right, so
Right.
some of mine are the same. Exercise, I think we've talked about that. I think we need to, you know, manage our weight better. I mean, I need to manage my weight better, but I think that we all need to be at a healthy weight. Limit alcohol or not drink at all. Avoid tobacco products in all forms. And I think it is important to have a primary provider so you can get your screenings like, you know, your mammogram, your bone density, your colonoscopy. And then I'll just add one more. I just have to add this because we said healthy and happy. We need something to make our face light up. And for me, that's grandchildren. So if you don't have grandchildren, you know, those grandchildren make you
Go adopt
healthy.
some.
Yeah.
I love it. Okay, well, since I have a wellness program and I have 11 essential elements to health and happiness, I had to narrow it down, okay, because I only said 5. And I love it. I was just taking a lot of things for granted. Don't smoke. I didn't even think about putting that on the list, you know. Don't smoke, okay? Number 1, maintain an ideal body weight. We now know that fat tissue is not just sitting there. It's releasing adipocytokines, these inflammatory chemicals. That's why if we have excess body fat, we're at higher risk for strokes, heart attacks, Alzheimer's disease, diabetes, breast cancer. I mean, it's because that fat tissue is releasing bad stuff. Okay, so maintain an ideal body weight and then meet or exceed the exercise guidelines. And I challenge everybody to go for the 300 minutes a week. 300 divided by 7, I think is 43 minutes. Can somebody check on that? 43 minutes a day, and you're worth it, okay? And because we're sitting so much behind computers, screens, TVs, finding that time. So I'm going to challenge everybody to work that into their schedule. You're worth it. And avoid or limit alcoholic beverages. If you don't drink, don't start. And I guarantee you, I had to prepare an hour-long talk on cancer prevention for the Baylor Scott and White Health Plan, which I did a webinar today, which we're going to have to do is, I'll have to do it as part of this. And even after looking at all the data, you know, I think I'm going to start limiting my wine to maybe 1 or 2 glasses a week, if that, because the data is so strong on alcohol having just a lot of bad effects. throughout our body, not only on the breast, but even increasing our risk of Alzheimer's disease. And the other thing is kind of going along with meditate, pay a visit to yourself, reduce stress. And Jeff and I are now currently started a webinar series. In fact, the first webinar was this week, 13 weeks in a row. And every one of those webinars we're ending with a meditation. Through the 13 weeks, Jeff is going to teach everyone how to meditate. So we're very excited about that. If you have any questions about it, we have a booth out there, and anybody that registers gets a free book and workbook and all. And I also put on here sleep. Sleep. Not just the number of hours of sleep, but the quality of our sleep. And I actually monitor my sleep with a sleep ring. And I get up every morning and check my score. So we can think that we're sleeping well, but we're not getting enough sleep. And one of the webinars that we do, Jeff and I do in the 13th series, is just understanding sleep, the stages of sleep, how sleep changes as we age. It's fascinating, fascinating. And what we can do to get healthier sleep. Because when we're sleeping, it's not like the body's doing nothing. It's actually detoxifying and consolidating memory and doing some wonderful things. So sleep is really important. So what I want to do now, Sherry, is I think we can take some questions here.
And I would jump in as we're waiting for a question in the exercise. Like if you can't do 43 minutes today or tomorrow, sometimes you may not have the time or the tolerance for that. Do 20 minutes and then park at the end of the parking lot or take the stairs or do something little. So it doesn't have to be 43 minutes tomorrow. It's not all or nothing. So just building that and increasing it, I think.
It doesn't have to be all at once. You can do 10 minutes here, 15 minutes there, getting that in during the day. Good point.
And the other thing about exercise, I have people all the time say, oh, well, my knees hurt. I can't get out and walk. But everybody, when I walk in the room, is on their phone. And I say, do you know how to get on YouTube? Get on YouTube and look up chair exercises. You can find all sorts of things to do just sitting. And Patsy, I have a question. Tell me about a sleep ring. I don't know about a sleep ring. Tell me about that.
Oura is the one I use. It is fascinating. It'll tell me my heart rate variability during the night, which that's when you want to know your heart rate variability is at rest. What my heart rate was doing during the night, how much deep sleep I got, how much REM sleep I got. It's incredible.
Can it measure that?
Oh, yes.
Yeah.
Oh, yeah. It's fascinating. And there's other companies that measure sleep also, but we can actually, you don't have to go get if you're having a specific sleep disorder, you may need a special sleep test. But there's so many ways now that we can monitor our sleep.
And not having a glass of wine right before bed is one of the best ways to improve your sleep.
Yes. Oh, yeah.
Yeah.
Sleep hygiene, very important, the things that we can do. So questions? Yes.
I've heard conflicting information about soybeans, whether to eat them or to avoid them.
If you want to eat them. They're not medicinal. They don't harm you, but you can eat them if you want to. They don't increase your risk for breast cancer.
The estrogen component?
No.
Okay.
No.
Yeah, only about a third of women have the necessary enzyme to convert that into any kind of meaningful estrogen.
You'd have to eat a hell of a lot of soy. Actually, fat tissue makes estrogen. There's hormones that are in fat tissue that are converted to estrogen. And that's why one of the reasons that women who are overweight have an increased risk of breast cancer and cancer of the uterus.
And heavier periods.
What?
And heavier periods.
And heavier periods, yes.
Okay. My question, I'm going to try to wrap it 3 into 1. But after menopause, why is constipation more prevalent, belly fat more prevalent, and do collagen supplements help?
The midline weight gain is one of the most common complaints in the menopause that we see. And there is some hormonal trigger to that, but it's more so lifestyle and dietary intake. That's been looked at a lot of different ways. And so really it's modifying the exercise dietary modification for that. Anybody have an opinion on collagen supplements?
I mean, I use them for my joints and I feel like they help, but as far as a weight loss tool, not necessarily. And then I talk to people about that weight gain at the end of puberty. Again, it mimics it at the menopause as well. It takes a lot of energy to bring a reproductive system online and then to maintain it. So that's why teenagers can eat like they have holes in the bottom of their feet and just falls through them. But then they go to college or puberty ends and people do put on a lot of weight and they blame the hormone pills for it. Well, metabolism is naturally slowing down around the age of 18. And then it slows down again when the reproductive system starts to really slow down. We no longer need all that energy to get ready to have a baby every single month. So again, if you're maintaining that same food and exercise intake, but then our metabolism slows down, weight gain is going to be a natural byproduct of that.
Yeah, I think that we have this thought or this philosophy is as we age, we can slow down. No, this is the time we need to up our game. Is everybody getting that? When you're younger, you can get away with this, but as we age, this is when all the cancers start to occur, the heart disease, the strokes, the Alzheimer's, because we've worn our body down. Aging is not thought of as a natural process. At these longevity clinics at Harvard and USC and all, aging is looked at as a disease caused by DNA damage over the decades. And a lot of that DNA damage is by what we're doing. Excess body fat, alcohol, just bringing in bad food, not exercising. So believe me, I exercise a lot more now than when I was younger. And if you would have told me, 20 years ago that I was going to have to eat the small amount of food that I eat, to keep my weight where it is, I would have told you were crazy. But you'd have been right. Our body doesn't need as much food, and it needs healthy food. But we can find everywhere we go that there's food. So this is a time for us to kind of question what society's offering us, and this is a time for us to up our game, up our healthy food consumption game, up our activity game, because our body actually wants to get rid of this excess fat. It's called autophagy. It's the body's recycling system. But it won't go to it unless you force it to. It's going to take what we it's going to burn what we take in first, because that's the easiest for it to metabolize. And it's not going to go to the excess sources unless we force it to. And the way we're going to force it to it is not eat so much and not eat as often, and to move, to exercise. So I think that's why all of us had physical activity on our list. And I think it's something that we all do. The panel up here.
I had a question. So lots of great information presented tonight. Thank you very much. And so exploring these strategies presented this evening on menopause, do you recommend talking with your general practitioner about it, or to see a specialist going forward to work on some solutions? Or
I think it depends on your general practitioner. I think that's a great place to start the conversation. And if they're comfortable managing that, that can be a great first source. And if they're not, then the ability to refer to a specialist.
You all spoke of how important sleep is. What if you cannot get 7 or 8 hours of sleep? You can't go to sleep, or either you sleep 4 hours and you wake up and cannot go back to sleep. And is it better to get up, or is it better to just stay in bed and lay there and rest?
Well, that's about an hour discussion, and we're going to have sleep as one of the topics. If people are having specific sleep disorders, a lot of times they do need a sleep study, and they need to look at what's going on. A lot of times you wake up and your mind's racing, and you're thinking about something, and I'll find myself doing that, and then I'll go, Patsy, you don't need to be thinking about that now. You need to be thinking about sleep. And I'll start thinking about sleep, and I must fall asleep because I fall asleep. but that's what we call early morning awakening or waking up in the middle of the night, and there's a whole lot of causes for that, and probably out of our area, unless you guys want to comment on that.
Other than exercise does help, moving back to that same theme, is not exercising right before bed, because that can disrupt your sleep as well, but getting daily exercise every day where you actually have that physical need for sleep. But the needs for sleep changes throughout your lifestyle, and again, if you feel like you're fatigued all throughout the day, you're exhausted, you're falling asleep during the day, then you should get a sleep evaluation. But you may not need as much sleep as you think you need, and everybody is different. There's not a set recommendation for exactly 7 or 8 hours of sleep. It's a fairly wide range. So if you are concerned, I would suggest talking to your doctor about getting a sleep evaluation.
And I think that's really important, but sleep hygiene is also really important. We have screens in our rooms, alcohol at night, and so sleep hygiene, and if you're not really sure what that entails, most major medical centers, you can kind of Google sleep hygiene and get some great recommendations as far as like light in your room, sleeping in a cool environment. Maybe your partner needs a sleep evaluation, different things that you can do to make sure you get good sleep.
Yes.
You said that periods usually started at age 16 or back when, at least when I did. What is the normal age now that you're seeing for girls in starting periods?
Great. That's a great question. And the range is actually fairly wide because those studies were looking at mostly thin white girls, and now we have a much broader definition based on different ethnicities and different races. Generally, if you are non-Black, non-Hispanic, you can start as early as 8 and is considered, as early as 9 and considered to be normal, and we are seeing that frequently. And in Black and Hispanic girls, the norm is considered as early as 8. As far as
what do you see is causing that to be so early? Why are they seeing it earlier?
It's a wide variety of reasons, and some of it may be genetic. Because we do tend to see this run in families when mothers and daughters, but it's not exactly set like that. We are seeing earlier menarche for girls who are more obese. There is question on whether some of the foods with different hormones added to meat and milks could be contributing to that, so it's not entirely clear cut. And then as far as too late, that range has happened too. So as long as puberty is progressing, and so we're seeing breast development and hair development and height is increasing, then we give it a little bit wider berth to age 14, 15 before raising the alarm. But if you're not seeing any development and a girl is 12, 13, 14, then we need to start an evaluation. If by late 15, early 16, no periods have started, then there needs to be an evaluation. It doesn't mean that there's necessarily anything wrong, but perhaps a girl is too thin. Perhaps that she's an athlete, and we've called it a variety of different reasons now, but the term is called relative energy deficiency. And the flip coin of eating too much fat and being overweight and causing a hormonal dysfunction, the other side could be too thin and not having enough energy intake, calorie intake. And again, another whole conversation on another day, but then we're starting to think, is this an eating disorder? Is this pressure from maybe a coach? Girls are a lot of pressure to not gain weight for athletics, so that's another potential reason to late start.
Also, oh my gosh, I had a period question. So I know y'all were saying that whenever, with like the period suppression, right? So like with menopause, you were saying a lot of times you see that weight gain because you're not having those hormones anymore. Can that same kind of thing happen with the period suppression? So like having an IUD for a long period of time, can that cause that weight gain also?
No, the evidence really hasn't played out on that, and in most of the hormonal medications, which we use are specifically contraception, most of them do not show any significant weight gain. There are a couple though. Depo-Provera, which is the every 3-month contraception injection, is really the only one of contraception that's truly been associated with significant weight gain, and that's only for some people. the amount of progesterone, which can suppress periods, especially at higher doses, can be associated with weight gain. And really the thought is it stimulates hunger. So I've actually had patients sit in front of me unwrapping a Big Mac telling me how fat the depot shot is making them. But again, a lot of it depends on what they're putting in their body. Some of the weight gain at really high doses of progesterone, though, can come from fluid retention. So some of that is water weight gain, which will stop which will be flushed out after that progesterone is stopped.
Yeah, when you're talking about no periods in menopause and the weight gain, those women have no estrogen. When we talk about menstrual suppression, like with the IUD, the ovaries are still making estrogen. And when you're on birth control pills, you're getting estrogen.
And one of the joys
So
about
it's a menopause is
and the
no
IUD
estrogen.
is wonderful because it only absorbs about your body only absorbs about 20% of that progesterone versus either an oral progesterone, an injection, or an implant. So relatively very little of that progesterone is absorbed. So it tends to have the lowest weight gain, lowest side effects, lowest mood changes, lowest rates of acne.
What is the latest evidence on hormone replacement therapy and breast cancer risk?
Okay. You want to take that?
Okay. You know, there was a big study that came out a few years ago, Women's Health Initiative, that said that women who take estrogen and progesterone together, and you need progesterone if you still have your uterus, that combination increases the risk for breast cancer. But estrogen alone does not increase the risk for breast cancer. So, you know, years ago, we would start women on hormones and keep them on for ever and ever and ever. But now there's more of a, you know, we sort of get them to the normal age of menopause, and then we'll taper and stop the hormones. You may want to say more, Kelly.
Yeah, the newest 2022 guidelines, which is the first time they've been updated in about 5 years for hormone therapy, is that in general, for most women, whether it's estrogen alone or combined, for women that are having symptoms, the benefits outweigh the risk within the first 10 years of menopause. So not for long term, but in that initial period, that benefit tends to outweigh the risk. And there was recently a published paper kind of in a follow-up to this study that showed that estrogen alone actually decreased the risk of developing or dying from breast cancer. That combined therapy, estrogen plus progesterone, did have a slight increase in the incidence of breast cancer, but no change in the risk of dying from breast cancer.
So if you once again, it's risk versus benefits. And if we look at the benefits of being on hormone therapy, if you're a menopausal woman, it protects your bones. And actually, more women die from hip fractures than breast cancer. Hip fractures kill women. So we have to remember this. We also now have evidence now that estrogen can lower our risk of heart disease. Although it's not FDA approved, the FDA said put it in the package insert. And there is some data on better cognitive function, but we'll never have the definitive study on that. So one has to weigh the benefits in a particular person against the risk. And so for a lot of women, the benefits do outweigh the risk, but people haven't taken the time to explain this to patients, And the progestin that caused that rare increased risk in breast cancer was medroxyprogesterone acetate. There are other progestins that may not have as much of a proliferative growth effect on the breast. And some studies on that. So we only have that information with that one progestin, which was MPA, medroxyprogesterone acetate.
And we've really been downing the alcohol, but there is some also recent information that the risk of breast cancer with the combined hormonal therapy, estrogen plus progestin, has a similar risk to consuming 2 alcoholic drinks per day. So again, it's in context in light of other risk factors.
Exactly. I mean, all of these things that sometimes we can avoid a medication that has all of these benefits because we're concerned about that rare increased risk of breast cancer, but we're not working on our exercise, getting rid of the excess body fat, not limiting the alcohol. Because life is an odds game, okay? The odds are not just in Las Vegas, folks. The odds are in everything you and I do. Every action you and I take is a vote. It's a vote down a healthy path or an unhealthy path, and it's a vote on how much we value ourselves. And I suggest, has been suggested by the panelists, that we do value ourselves. We have a purpose in our life. But everything we do, we're casting a vote. And so let's make sure that that's working for us and not against us. That's it. I want to thank our panelists.
Yes, big round of applause for these guys.